Welcome to the Endocrine Essentials. In this video, we will explore one of the most common endocrine disorders, hypothyroidism. The thyroid gland may be small, but it plays a vital role in regulating your body's metabolism, energy production, heart rate, body temperature, and even the brain function. When the thyroid fails to produce enough hormones, every system in our body slows down. Patients may present with fatigue, weight gain, cold intolerance, constipation, dry skin, depression, or slowed thinking. If left untreated, hypothyroidism can lead to serious complications, including cardiovascular disease, infertility, and Myxedema Coma. In this high yield lecture, we will cover the anatomy and physiology of the thyroid, causes of hypothyroidism, clinical features, diagnosis, treatment, and important examples for different exams. So, let's begin by understanding how the thyroid gland controls the body's metabolism and why thyroid hormone is essential for normal health. To understand hypothyroidism, we first need to understand the hypothalamic-pituitary-thyroid or HPT axis, the body's thyroid controlling center. It all begins in the hypothalamus, which releases the thyrotroponin releasing hormone or TRH when the thyroid hormone levels are low or during the cold exposure. TRH then stimulates the anterior pituitary gland to release the TSH, that is a thyroid stimulating hormone, into the bloodstream. TSH travels to the thyroid gland where it stimulates the production and release of the thyroid hormones T4 and T3. About 80% is T4 and 20% is T3. As T3 and T4 levels rise, they exert negative feedback on both the hypothalamus and the pituitary, reducing the release of TRH and TSH. This feedback loop maintains the normal thyroid hormone levels and keeps the metabolism in balance. In primary hypothyroidism, the thyroid gland fails to produce enough T3 and T4, causing the TSH levels to rise. This principle forms the basis for diagnosing the thyroid disorders using the thyroid function test. Now, let's see the thyroid hormones working inside the body cell. The thyroid gland mainly releases T4, which is converted in peripheral tissues into the more active hormone T3 by the enzymes called deiodinase. T3 then enters the cell nucleus and binds to the thyroid hormone receptors, where it regulates the gene transcription. This activates gene responsible for energy production and normal cellular function. As a result, the number and the activity of mitochondria increases. The sodium potassium ATPase pump becomes more active. Oxygen consumption rises and more heat is produced. Together, these effects increase the body's basal metabolic rate and provide the energy needed for the daily activities. In hypothyroidism, when T3 and T4 levels fall, every cell in the body slows down. This leads to fatigue, weight gain, cold intolerance, constipation, dry skin, and reduced physical and mental performance. The key takeaway is simple: thyroid hormones are the body's metabolic engine. When T3 and T4 decreases, the metabolic rate of every cell decreases as well. Let's apply these concepts to a real clinical case. Meet Mrs. Sunita Verma, a 38-year-old homemaker who presents with fatigue and a 6 kg weight gain over past 8 months, despite no significant changes in her diet. She also reports that severe cold intolerance, constipation, dry skin, diffuse hair thinning, and heavy, irregular menstrual cycles. Her family history of thyroid disease further raises the suspicion of hypothyroidism. Now, let's examine her laboratory findings. TSH is elevated at 38.6, while her T4 is significantly reduced to zero point 0.4. She also has a positive antithyroid peroxidase or anti-PO antibodies confirming an autoimmune process. In addition, her hemoglobin is mildly low, explaining part of her fatigue. These findings are classic for primary hypothyroidism caused by Hashimoto's thyroiditis, the most common cause of hypothyroidism worldwide. In the next slides, we will discuss the diagnosis, treatment, long term management of this patient. Many symptoms of hypothyroidism, such as fatigue, weight gain, and cold intolerance, are non-specific and may be caused by many conditions. So, what is the best first diagnostic step? Avoid starting levothyroxine based only on the symptoms and don't order a complete thyroid panel for every patient. Instead, the most sensitive and cost effective initial screening is serum TSH. If TSH is abnormal, then measure free T4 to confirm the diagnosis and determine its severity. Free T3 testing is usually not required for routine diagnosis of hypothyroidism. Always confirm hypothyroidism biochemically before starting the treatment. This evidence based approach ensures accurate diagnosis and appropriate management. Before we move on to the treatment, let's review some common diagnostic mistakes that every clinician should avoid. First, never diagnose hypothyroidism based on the symptoms alone. Fatigue, weight gain, and cold intolerance are nonspecific, so always confirm the diagnosis with a TSH test. Second, avoid ordering total T3 and total T4 routinely. Pregnancy and oral contraceptives can alter binding proteins, making total hormone levels misleading. Free T4 provides a more accurate assessment. Third, remember that the TSH alone is not reliable in suspected central hypothyroidism. If the pituitary disease is suspected, always interpret free T4 along with the TSH. Finally, after starting or adjusting levothyroxine, don't forget to recheck the TSH after 6 to 8 weeks. This allows enough time for hormone levels to stabilize and ensures the dose is appropriate. Avoiding these common pitfalls leads to earlier diagnosis, better treatment decisions, and improved patient outcomes. Now, let us put everything together into a simple evidence based approach for diagnosing and treating hypothyroidism. Step 1 is screening. Order TSH as the first line test in any patient with symptoms suggestive of the hypothyroidism. Step 2 is confirmation. If TSH is abnormal, measure free T4 to confirm the diagnosis and determine whether the disease is overt or subclinical. Step 3 is to identify the underlying cause. In most cases, testing anti-TPO antibodies helps to confirm the Hashimoto's thyroiditis, the most common cause of primary hypothyroidism. Finally, start weight-based levothyroxine therapy and monitor the patient's response. Recheck TSH after 6 to 8 weeks and adjust the dose until the target TSH is achieved. For our patient, Ms. Sunita Verma, the diagnosis is overt primary hypothyroidism due to Hashimoto's thyroiditis, and she was started on appropriate levothyroxine replacement therapy. Hypothyroidism exists on a spectrum ranging from mild disease to life threatening illness. At the mild end is the subclinical hypothyroidism, where the TSH is elevated but free T4 remains normal. Many patients have few or no symptoms. Treatment is considered if the patient is symptomatic, pregnant, planning pregnancy, or if the TSH is above 10 ml per liter. The next stage is overt hypothyroidism, characterized by a markedly elevated TSH or low free T4. Patients develop classic symptoms such as fatigue, weight loss, cold intolerance, constipation, and dry skin. These patients require levothyroxine replacement therapy. At the most severe end is the Myxedema Coma, a rare but life threatening endocrine emergency. If the patient presents with severe hypothyroidism, hypothermia, bradycardia, altered mental status, and carries a high mortality rate, immediate intensive care and IV thyroid hormone replacement are essential. Recognizing where a patient falls on this spectrum helps you guide timely treatment and prevent serious complications. Interpreting thyroid function tests becomes much easier when you understand a few key patterns. In subclinical hypothyroidism, TSH is mildly elevated but free T4 remains normal. These patients may have few or no symptoms. In overt primary hypothyroidism, TSH is markedly elevated while free T4 is low. This is the classic pattern seen in Hashimoto's thyroiditis and requires thyroid hormone replacement. In central or secondary hypothyroidism, the problem lies in the pituitary gland. As a result, TSH is inappropriately normal or low, even though free T4 is low. That's why TSH alone cannot diagnose the central disease. Finally, in sick euthyroid syndrome, thyroid hormone levels may appear abnormal during the severe illness, but the thyroid gland itself is usually normal. Treatment should focus on the underlying illness rather than the thyroid hormone replacement. Here is the golden rule. In primary hypothyroidism, TSH rises because the pituitary is responding normally. In central hypothyroidism, the pituitary fails to respond. So, the TSH cannot rise despite low thyroid hormone levels. Hypothyroidism is not just a thyroid disorder, it affects nearly every organ system in the body. In the brain, reduced thyroid hormone levels can cause cognitive slowing, poor concentration, memory impairment, and depression. These symptoms are often mistaken for normal aging or stress. In the cardiovascular system, hypothyroidism increases LDL cholesterol, accelerating the atherosclerosis. In severe cases, it also may lead to pericardial effusion and reduced cardiac function. In the blood, patients may develop normocytic or macrocytic anemia, contributing to fatigue. This occurs due to reduced erythropoietin production and, in some cases, associated vitamin B12 deficiency. The reproductive system is also affected. Women may experience menstrual irregularities, infertility, recurrent pregnancy loss, and pregnancy complications if hypothyroidism is left untreated. The message: early diagnosis and appropriate thyroid hormone replacement not only relieves symptoms but also prevents these widespread systemic complications. The most life threatening complication of hypothyroidism is Myxedema Coma, a true medical emergency with a high mortality rate. Remember the classic trait: hypothermia, severe bradycardia, and altered consciousness or coma. Any patient with these findings requires immediate recognition. Other important clues include hyponatremia, unexplained pericardial effusion, and even carpal tunnel syndrome, which can occur due to mucopolysaccharide deposition. Management begins with ICU admission and supportive care. Treatment includes IV levothyroxine, but before administering thyroid hormone, always give IV hydrocortisone to cover possible coexisting adrenal insufficiency. So, suspect early, treat immediately, and never delay therapy because prompt intervention can be life saving. Let's finish with a high yield exam question. A 45-year-old asymptomatic woman has a TSH of 8 milli international units per liter with a normal free T4. What is the next best step? The correct answer is B. Recheck the TSH in 6 to 12 weeks. This patient has subclinical hypothyroidism. In asymptomatic patients with the TSH below 10, immediate treatment is usually not required. Instead, repeat the thyroid function test to confirm the persistent elevation and rule out temporary changes. Remember, treat immediately if the TSH is 10 or higher. If the patient is pregnant, symptomatic, or has a specific high risk features. Otherwise, confirm the diagnosis post with repeat testing. So, here is another high yield exam question. A patient with a known pituitary tumor has classic symptoms of hypothyroidism. The TSH is normal at 1.2, but the free T4 is low. What is the diagnosis? The correct answer is central hypothyroidism. This is called the TSH trap. In pituitary disease, the pituitary gland cannot produce enough TSH even when the thyroid hormone levels are low. As a result, the TSH may appear normal or low, making it unreliable marker. So, if the pituitary disease is suspected, never rely on the TSH alone. Always interpret TSH together with free T4. A low free T4 with an appropriately normal or low TSH strongly suggests central hypothyroidism. Let's conclude with some practical points for everyday clinical practice in India. Today, Hashimoto's thyroiditis has become the most common cause of hypothyroidism in iodine sufficient urban populations. However, iodine deficiency still remains a concern in the parts of sub-Himalayan region, so always consider the patient's geographic background. When prescribing levothyroxine, proper counseling is essential. Advise patients to take it on empty stomach at least 30 to 60 minutes before breakfast for optimal absorption. Also, remind them to keep a 4-hour gap between levothyroxine and calcium or iron supplements, as these can significantly reduce drug absorption. Finally, to avoid switching between the different brands unless necessary. If a brand change occurs, repeat the TSH after 6 to 8 weeks to ensure the dose remains appropriate. These simple counseling tips can greatly improve treatment success and long term patient outcomes. The thyroid may be a tiny gland, but it powers every cell in our body. Understanding how it works can help you recognize the disease early and treat it effectively. Remember the golden rule. TSH is the best screening test and free T4 confirms the diagnosis. Always interpret thyroid test in the right clinical context. Also, let me know your personal TSH reference range in the comments. Thank you for watching. I hope this lesson helped you understand hypothyroidism with confidence and made the topic easier to remember. If you found this video valuable, please like, share, and subscribe our channel for more evidence based high yield medical content. Feel free to leave your questions or topic suggestions in the comments below. Until next time, keep learning, keep growing, and stay healthy. Thank you, and see you in the next video.